Hello and welcome to this lecture titled Are We There Yet? Confirming NGT or nasogastric tube placement on a chest radiograph, also known as a CXR. I'm Dr. Ian Tay from the Singapore General Hospital, and I have colleagues Mr. Ng Chow Yong from Changi General Hospital, as well as nurse clinician Chu Pei Tia from Sengkang General Hospital, who have helped me in the preparation of this lecture. We have no conflicts of interest to disclose. These are the learning objectives for today. By the end of the lecture, you should be able to list the indications for an NGT CXR. Number 2, you should be able to recall the limitations of an NGT CXR. And finally, you should be able to interpret an NGT CXR with regard to whether the tube is in the right position. This is the outline for today's lecture. We'll go through them one by one. There are 3 types of feeding tubes available in SingHealth. And you will find that the most common one, as used in many of the inpatient wards, will be the Riles tube. After a feeding tube has been inserted, the nurse will check for any aspirate and also look at the pH value of that aspirate. If there are no aspirates or if the pH value is more than 5, this indicates that the tube may not be in the correct position, and this nurse should then escalate to a more senior nurse to verify placement. If together they are still unable to determine correct placement of the tube, they can then escalate this to the doctor, who can request for a chest X-ray to check on the placement of the tube. There are some limitations of a chest X-ray with regard to NGT placement. The first is that a chest X-ray has a risk of being misinterpreted. Second, a chest X-ray comes with a small dose of radiation. Third, we must consider that there may be a loss of feeding time whilst awaiting for the chest X-ray. In some hospitals, due to limited logistics, this may take longer. Also, for patients in the community setting, such as in a community hospital or in a nursing home, access to such chest X-rays may be more limited. Finally, please remember that there is also a cost both to the hospital and to the patient for performing this chest X-ray. For doctors, you can order a chest X-ray through the Sunrise Clinical Management software, and on the request form, please remember to indicate under the reason for exam that this is to check for NGT placement, and please also try to include details such as whether no aspirates were obtained or whether the aspirate was seen to have a pH of more than 5. As part of the ordering process, please note that this should be done with a routine request. Please clearly state whether this is also a post-insertion or a post-readjustment chest X-ray. Those of you who are from radiography, well, the first consideration is to ensure that the exposure factors are optimized so that you can clearly see on the radiograph where the tip of the feeding tube is. Second, we must place the detector a little bit lower so that we can see some of the abdominal region and hopefully be able to identify the exact location of the tip on the chest X-ray. If the tip of the feeding tube is really low down, you can also perform additional cone down views of the abdomen to visualize the tip. Finally, we must try to ensure that the patient is not rotated during imaging because, as we can see later, this might cause misinterpretation of tube placement where the tube is splayed very far off the midline. These are some of the landmarks that you will see on a normal chest X-ray. I'd like to suggest that you start off by identifying the trachea. This is the lucent portion, which is just in the midline, and you can see how it bifurcates on one end to the right main bronchus and also to the left. And in between that, you will find the carina, which is an important landmark for interpreting an NGT CXR. Finally, please take note of the position of the hemidiaphragms. Before you jump in to interpreting the chest X-ray, please do a safety check. Ensure that you are interpreting the chest X-ray of the correct patient by checking the name and identification number. Second, also look at the date and time of the chest X-ray. Sometimes a patient may have multiple chest X-rays performed within a short period of time, and you want to make sure that you are looking at the chest X-ray performed at that correct time. There are 4 basic criteria to fulfill for which we can then say a nasogastric tube is correctly and safely sited. The first is that the tube should remain in the midline down to the level of the diaphragm. Second is that the tube should bisect the carina. The third criteria is that the tip of the tube should be clearly visible and below the left hemidiaphragm. The fourth criteria is that the tip should be approximately 10 cm beyond the gastroesophageal junction. This would place it safely within the stomach. And if any of these criteria are not met, and if you have any doubts, please seek advice from a senior colleague or discuss with a radiologist. Let's start with this chest radiograph. First up, look for the trachea, which is the loosened structure in the midline. Then, look for the loosened structures at both hilar regions. On the left main bronchus, and on the right main bronchus. Where they bifurcate is where you'll find the carina. Sometimes these structures in the mediastinum may be a little bit difficult to identify, and you may have to window the film to find the correct level of contrast. Underneath the left hemidiaphragm is where you'd expect the stomach to be. Sometimes you may see a gastric bubble of air there. And the medial aspect of the left hemidiaphragm is normally where the gastroesophageal junction is. And in this case, you can see that this feeding tube is clearly beyond the gastroesophageal junction. This tip is very far away from it and safely sighted. One thing you want to note is that sometimes tubes have side holes, and you have to ensure that the most proximal side hole on the tube is sighted at least 10 cm from the gastroesophageal junction. Practice number 2. First, identify the trachea, which is the loosened structure in the midline, and then identify the left-sided loosened structure at the level of the hilum, which is the left main bronchus, and then the right main bronchus. Look for where they bisect, and you'll find the carina over there. In this case, the tube bisects the carina, and this means that it is at least within the esophagus. You can see the gastric bubble here, underneath the left hemidiaphragm, and you see that the tip of the feeding tube is beyond the inferior border of the radiograph. Nevertheless, it is suitably far away from the expected location of the gastroesophageal junction, so this tube is in satisfactory position. Practice number 3. First, identify the trachea, which is the loosened structure in the midline, and from there, we can trace it towards the left main bronchus and the right main bronchus. The carina is where you'll find the bifurcation of the trachea, which is over there. And then you can see in this film that the tube bisects the carina, meaning that it is at least within the esophagus. Under the left hemidiaphragm is where you would normally expect the gastric bubble to be, and at the medial aspect of the left hemidiaphragm is where you would normally expect gastroesophageal junction to be. In this case, the tip of the feeding tube is very close to the gastroesophageal junction, and this tube needs to be advanced further before you can start feeding through the tube. First, identify the trachea in the midline in this film. Then, you can see where the left main bronchus is and the right main bronchus. In this case, you see that the tube is within the loosened structure of the trachea, and it roughly follows the path of the right main bronchus. It does not bisect the carina, which means that this is probably not within the esophagus. Over there, you can see the location of the gastric bubble under the left hemidiaphragm. Note that the tip of the tube is very far away from this expected location. You can also see where the expected location of the gastroesophageal junction is, and once again, the tube is very far away from this location. In totality, this tube is probably within the airways and needs to be repositioned before you can commence feeding through the tube. You've seen this X-ray just now. Let's practice one more time. First, identify the trachea, which is the loosened structure in the midline. Next, identify the left main bronchus, followed by the right main bronchus. With that, locate the carina. And in this film, you can see that the feeding tube bisects the carina, indicating that it is at least in the esophagus. Then we identify the expected location of where the stomach is. Also, with that, at the medial aspect of the left hemidiaphragm, the expected location of the gastroesophageal junction. In this film, the tip of the feeding tube is probably just beyond the gastroesophageal junction, but it is a bit too near. This tube needs to be advanced further before you can start feeding through the tube. In summary, first, perform a safety check. Verify that it is the correct patient that you are looking at, and also verify that the date and time of the chest X-ray are correct. Next, remember the 4 criteria, which are that the tube should remain in the midline. Number 2, that the tip should bisect the carina, indicating its location within the esophagus. 3, that the tip of the tube should be well below the left hemidiaphragm. And number 4, that the tip or the most proximal side hole of the tube should be at least 10 cm from the gastroesophageal junction. These are some references. We would also like to acknowledge the contributions of the following members as part of our education team. Thank you all for tuning in.